Today, we have with us once again Professor Kartik Jhaveri. He is the Director of Abdominal MRI in Joint Department of Medical Imaging in Toronto.
You put someone in a magnet and you get these amazing internal detail without radiation.
When we are looking at imaging overall with ultrasound versus CT versus MRI, we find that patient wait times and access for MRI has always been the longest.
It's important for us to drive the field further. You need to really find those areas. And this is not just related to MR, it's related to any field, not just medicine.
It's always a pleasure chatting with you. But last time we were chatting about research. But this time I want to ask you about MRI. And you've been shepherding abdominal MRI in JDMI, which is the largest academic center in Canada, for the longest time, ever since I've joined here. So how did you start into MRI, and how have things evolved ever since you started, like back during your medical school and residency?
Yeah, it's been an interesting journey. So my exposure to MRI started in the mid to late 90s when I was in residency. And I was always fascinated by MRI because I think it's actually magic. So you put someone in a magnet and you get these amazing internal detail without radiation. So it really kind of intrigued me into evolving into that field. And then just looking at the tissue resolution, the contrast resolution compared to other modalities, I just found it, very superior. And the most effective kind of endpoint in terms of, clinical decision making. And that's part of the reason I said this is the area to pursue. So, once I finished my residency, I did my fellowship in MRI and then, try to focus on both clinical and research in MRI. But when I look back at the mid-90s and early 2000, and I look at the practice now, there's a dramatic change as you have realized too during your residency and your fellowship over the last decade. In the mid to late 90s, it was all about anatomical imaging. It was all about, this is the problem-solving modality, as they used to call it.
Yeah.
Right? And that actually resulted in more problems because you didn't do MR as frontline. You actually waited till you did X-rays, ultrasound, CTs, and then only you would kind of do an MRI. And this would actually result in delay in diagnosis as well for patients. So that's something which has changed now. It's no longer considered just a problem-solving modality. You can access it directly for certain indications.
Yeah, first-line modality for a lot
of things. Like, for example, previously indications were very neuro and MSK heavy, and abdomen was mostly with ultrasound and CT, but that's not the case anymore. As we know, we scan a lot of patients for abdominal MR now. It's a huge chunk of our clinical practice. So that has been a big impetus in terms of change as well. Previously, we had really long scan times. I remember.
Yeah, I think that was primarily the issue with abdominal
MRI, right? And you would have a protocol which went on for 45 minutes to 1 hour, 15 minutes. And some of them were even without contrast examinations. And these were for large things, not for picking up 2 millimeter metastases that we're trying to do now.
Absolutely.
So that's the kind of shift we have gone over, the last 2.5 decades in terms of the quality and the resolution and the speed that we have now is there's no comparison between then and now in those sense.
Amazing. So from starting off as characterizing some huge masses, now we have actually gone on to MRI being the first line. For example, colon cancers. That's the best modality to pick up very, very tiny metastasis. So that's a great shift. And what drove all of this? Was it all software, hardware, or a combination of everything?
Yeah, so it's been a very complementary evolution, I would say. But I think the hardware came first. Like
Okay.
the basic change, maybe I would say a decade ago it was mostly the hardware change. So faster gradients, more channel coils, faster RF, that kind of implemented the platform for the software changes.
Okay.
But I would say in the last decade, it has been driven very heavily by software, as you can't escape the word AI today.
Yeah.
So that is all integrated into MR. And so the accelerated imaging techniques, such as, parallel imaging, Kuiperenia, and then, you put those on steroids and you get compressed sensing. And then now you have deep learning reconstruction techniques, and these have really revolutionized the speed and quality of imaging. So when I, was training, they always said you can have speed or resolution. You cannot have
you
both.
cannot have both. Yeah.
Right? That was the fundamental principle. But with the deep learning reconstruction techniques, you can have both.
Okay.
And I myself was not ready to believe it until we did our own study and we compared spatial resolution, image quality, and noise, and it is actually true. You are getting both with deep learning reconstruction techniques. So I think in the last 5 years, that has been, I would say, the number one advance in terms of increasing speed and quality. And that has like an overarching effect on the efficacy of MR in clinical implementation.
That's amazing. With all of these like software innovations and better quality, do you still think that there is that difference between 1.5 and 3 Tesla? Because the way a lot of things are marketed to patients is that all patients know is that, okay, this is 1.5, this is 3 Tesla, it has to be better. Is 3 Tesla always better? And
yeah, this is a very common question, and I get asked by people who are both in the field of radiology as well as outside the field of radiology, because there's so much marketing and hype around the field strength of a magnet. But it's like how you want to use them. I don't think one is superior to the other. It depends on the practice that you're doing, the kind of scan that you're doing. Both have their pros and cons. For example, 3T does have higher SNR, so you can have better spatial resolution. But as I just said, with deep learning reconstruction techniques, you can have both speed and resolution. So the 1.5 can do quite close through a 3T Tesla. And then a 3T does have disadvantages. The higher field strength limits patients who have implants, pacemakers. So these are significant limitations that 3T brings in. So, for example, if patients have bilateral hip prosthesis, we don't do prostate MR on a 3T. We have to do it on a 1.5T. So the 1.5T has to then carry the weight with those deep learning techniques to improve the resolution to come up to 3T. So I wouldn't say one is superior to the other or inferior to the other in that sense. And in fact, if you look at most academic departments, you always have a fleet which has both scanners or both field strands built into the fleet that you're hosting on site.
Okay. So, one might have more artifacts, one might have a better advantage in this.
Exactly.
So then, depending on what you want to do, then you kind of pick and choose. That's
exactly.
So you're saying that it's also important as to how you use them rather than having the machines themselves. So in that sense, when you have marketing, like for example, I know that due to some limitations in access here, and let's talk a bit more about that, many of our patients kind of go to other places like the US or Buffalo or something and kind of get scans and they advertise it as 3 Tesla. And sometimes when we see the images, they are not that good. So are there inherently differences between the 3 Teslas in different sites as well?
Well, it's how you use it, right? Like, so it's really important to know how to use a particular machine. And I think that optimization is very critical, whether it's whatever the field strength is. And that's where the expertise lies in, having that kind of background knowledge to, improvise your system to meet the quality that you want to bring out. So it can be variable, and that standardization is one of the issues that does exist in imaging, as you know, both across every modality that you look at, not just very specific to MRI.
Yeah, in other words, it's like you can buy an F1 car, but the person behind it is who matters. And if you don't know how to drive it, a good driver with a Toyota can easily overtake you.
certainly for now, we can say it's the person behind the wheel, but soon it'll be AI behind the wheel. So
Yeah,
I think the standardization will come.
Okay, perfect. And what are still some of the major problems with MR? Like when you started, it was only used in a very small number of indications. Now we are using it for much more. In fact, it's even used for almost screening now, for screening of prostate cancers and other programs. But what are still some of the issues faced with MRI overall?
Yeah, so I mean, there are certainly big challenges, and not to trivialize any of those challenges. I think for me, the biggest challenge is the cost and the resulting access, the limited number of hardware. Those are, I think, the fundamental issues which prevent further propagation. I mean, we have come a long way, and we have increased the utilization of MR dramatically, I would say, over the last 2 decades. But I think the cost is still an issue.
Is it just the cost of the machine, or anything
yes. Yes, okay. It's the cost of the machine, the cost of installation. So everything is related to the basic costs, right? Like, and then you need extra protection for, because you have helium involved. I'm sure there are new scanners which are coming out which are going to be helium free. Okay. But in general, construction of MR, as you know, is more complicated than construction for ultrasound or CT because of the protection that you need to built in for the strong field strengths.
Okay, so it's not just the machine, it's just the site, but then on top of that, you need like the Faraday cage around it, the site for the helium, so it just amps up.
Exactly. Okay. So everything ramps up, and there are certain buildings you cannot put it in. Mm-hmm. So there is a bit of more detail required in terms of installation. So I think those fundamental things are still going to continue for MR. It's not just the cost of the machine.
Okay.
I think some of the other things that we talked about are optimization and standardization. I think that is very critical. And I think standardization is good within, academic centers, but then standardization between academic and community centers, as you have seen, may not always be optimal. And something like that can be certainly improved to you kind of delay repetition of scans and have a more standardized quality across, the region or even the country. I mean, those are goals that we do need to meet. Some of the other limitations also come from safety. You do need to have a very strong MR safety profile, given the strong magnetic field, like we discussed, in terms of metal and implants. A lot of things can go wrong. As you know, there have been, in the past, the centers which don't have adequate safety protocols do have accidents, and that can give MR a bad name.
Always happens once every few years, despite all the safety. Somewhere in the world, you always find like one accident, freak accident.
Right. And how many times have you heard of that with CT? Almost never. Yeah. So those are some of the challenges because it is a specialized technique.
And it was actually where I did my training, one of my professors was like, okay, despite telling you guys as to how important it is, you might not realize. And he just stood at the end of the room. He had a coin in his hand. Just see what happens. It just flew.
Yeah.
And then you realize that even like something very tiny can become a bullet if it goes into that
Exactly. The acceleration and the velocity
is just insane.
It is dangerous, right?
Absolutely.
So I think MR safety is critical. That should be priority number one, apart from the quality standardization and the protocol standardization.
Yep.
Because the first goal of a physician is do no harm.
Yeah. Keep everybody safe, not just you and the techs and the patients as well. Yeah. All right. So, but we find that when we are looking at imaging overall with ultrasound versus CT versus MRI, we find that patient wait times and access for MRI has always been the longest. What are the major reasons for that?
Like I said, I think the fundamental issue is the number of scanners and the access.
Okay.
So that certainly is a big issue because of the cost involved, et cetera. So the capital investment or the capital expenditure into systems is vis-a-vis other units is more expensive. And ultimately, if you're buying, if you can buy 3 CT scanners with the cost of 1 MRI, it becomes very kind of tempting to not buy the MRI, right?
Yeah.
So I think that does put a lot of pressure on wait times.
Okay.
I think the flip side is that people have understood, like referring, medical practitioners have understood the real value of MRI now outside of neuro and musculoskeletal system. Okay. And the number of indications and the amount of,
demand for MRI.
Demand for abdominal MRI has skyrocketed. When I look at the numbers, even in our department, maybe when you started and when we are now, 5 or 6 years since you started, it has, I think, more than doubled actually.
Okay.
And,
okay.
We've been cutting on a protocol time, standardizing it, having abbreviated protocols.
So is
the
that
demand keeps coming.
So is that one of the major issues in which, despite all advances, it still takes a certain amount of time to scan a patient? It's not like CT in which you just walk in, 2 minutes, you're out. You still need at least like a 20, 30 minutes despite all advances.
Well, there are certain scans you can certainly slot times. We can get them down to like 15 minutes. But that's I would say on an average, the slot time would be around 20 to 25 minutes. So
okay.
Like currently our CT slot times are what? 10 to 15 minutes, even though the scan takes 30 seconds or a minute.
Absolutely. It's still like 15 minutes because patient bringing in, attaching IV and all that takes time.
So it is incrementally maybe 30 to 40% more time in terms of the examination. And that does also limit in terms of how much we can scan. But the fundamental issue is the number of scanners available, scanning time available. Are there enough MRI technologists available, which is also currently a challenge? Because remember, there is a specialist training required for becoming an MRT. So these kind of things, I think, all add up.
Interesting. And we find, as we were speaking about MRI, like initially, MR was like a fellowship. There was an MR fellowship. But now it's all subspecialty based. And abdomen is different from neuro and everything. So as these subspecialties start coming up, and because MRI is fundamentally different than CT, as CT, you just scan the whole body, everything. But MR is protocols in which you target specific organs and kind of do it. So as subspecialties start coming up, do you find that MR is becoming more fragmented over time, or is it?
I guess it's a yes and a no answer. It's not a perfect either way, and it depends on the kind of practice you have. So if you're in a tertiary or quaternary academic center, then certainly you have more specialized protocols. You have a bit more fragmentation. So for us as abdominal radiologists practicing in a quaternary referral center in the country, the kind of indications we see are somewhat different than a general community practice, and there are some special protocols that we do that the other community centers don't. So it does result in some kind of fragmentation, and as we go more and more deeper into subspecialization, I think you kind of lose track of the other body parts. So if somebody asks me, read this neuro-MR now, I can't read it.
Absolutely. Yeah.
So on the flip side, I think for a community radiologist, if they don't have certain key people who are not subspecialized in their practice, I think it becomes extremely difficult to keep abreast of everything. I think it's extremely challenging to do that in this day and age, opposed to I would say 25 years ago, because the amount of just an example, the amount of RAD systems that we use for reporting are skyrocketing, and sometimes I lose track of them myself. How do you expect someone to know all the RAD systems from head to toe all the time? So it requires a lot of effort. I think one solution is to have a core of standardization across all body parts.
Okay.
And then, implement the high-level subspecialty protocols at some centers only.
Okay.
I think that is one way to go. I think it's very difficult for one person to know everything. We know that.
Have something basic and then have areas of specialization.
Exactly.
For example, prostate, that's always comes up, in which people should have a certain amount of training and certain amount of
Sure.
cases per year so that they can keep up with
Exactly.
the
So that
standards.
kind of quality assurance needs to be brought in more formally in MR, and I think that's something that is missing. For example, in breast imaging, I think they are the beacon of quality assurance.
Absolutely.
Like
Yeah.
they've always been like the number
Forefront
one
of it.
to implement QA, and I think for the rest of the body parts, something like that would be really useful. I guess.
That would be great. But now that we're fragmented, and as you point out, like maybe you might not be able to read neuro or neck anymore and their specialization, we now move into the era of whole body MRI. And we find that it's coming up in a big way in many places. What are your overall thoughts about that?
Yeah, I mean, whole body has really, it's not a new thing. It's been around actually for 2 decades. Just,
Okay.
if you're aware of that, like it's been done in various centers across the world. I think it started off, as a solution for whole body oncology staging, like lymphoma and myeloma. And I think those are really good applications because you don't want to use radiation, constantly for surveillance of patients. So I think those kind of applications do help. And then certainly, as genetics has progressed, genetic medicine has progressed so rapidly as well. There is a need for screening high-risk groups with mutations. So I think those, indications are really very suitable for whole body MRI. And I think one of the other things that we have to also keep in mind that today we look at, ultrasound, CT, MR in silos, but really the answer is hybrid imaging and, things like PET MR. We've been doing PET CT for so long now, and PET MR is also taking off in a big way. So I think that's the future that I see for whole body MR.
We kind of seem to need a lot more scanners now. And where do you think we're going to get the scanners given that they are super expensive? Like with AI progressing, do you think that we can actually go the other direction, as in kind of have like lower field scanners to cheaper ones somehow to fill in the void?
Yeah, I think we have to do whatever it takes to increase the access. Apart from all the capital investment, which may or may not happen, certainly there is different. I'm not a finance person, but there are different models to finance these kind of systems, like public-private. Most countries are doing that, and I guess we are also, embarking on that route as well, as in Ontario, and there's going to be more non-academic center-related MR. So that's definitely going to have an impact. Certainly, low field strands are licensed to use now.
Low field strands, as in like, is it like
as a 0.55 Teslas?
0.5 Teslas?
Yeah.
So it's 1/3. Like
Yeah.
Okay.
Yeah. So certainly it's not the same as a 1.5 or 3T, but for certain rapid indications, fast indications, it is doable, including for abdominal imaging.
Okay.
Right? Like it's
especially
not
paired with AI.
Exactly. It's not just related to neuro or MSK. So there is a big push towards low field strength MRs because the cost is lower. It's not all that low, but it is lower.
Okay.
Yeah, just don't get excited by just saying that 0.55 will be really, really cheap. It is cheaper, not cheap.
And the scan times are also comparable?
I think the scan times are comparable. I think, but the fundamental cost is lower.
Okay.
So it does help increase the number of scanners.
Okay.
So in the future, I do see many centers, like for example, if I was to design a fleet of scanners today for the next 5 to 10 years, definitely I would include low field scanners in there.
Okay.
Because remember, one thing is we've always, MR has always been like in a silo at a particular site. And only now we are branching off into off-site and point-of-care access. For example, ultrasound is the fantastic example. The point-of-care ultrasound is amazing. You have ER, you have in the clinics, you have on the floors, on the wards. But we've never had that for MR other than OR. Maybe, in neuro ORs we have, a scanner actually.
Oh, we have a scanner in the OR?
Yeah,
Okay.
but at the Western actually. But, we've never had like a scanner in the ER, at least in our center.
Portable
right?
MRI in which you just push it.
So some of those things, like a 0.55T could help, like a, point of care access. I think that can alleviate it as well.
Yeah, especially like probably like a neuro trauma center and stuff like that, instead of having to shift the entire patient for something, or for a stroke center in which you can just quickly get it in.
Yeah, I mean, so some centers in the world already have all that kind of things, but I think we are getting into that
As of now.
near future.
That's interesting. So if you're designing a fleet, you'd have these low field magnets, but would you also consider the higher? Because we always like, I remember more than 10, 15 years ago, we were talking about like 7 Teslas and 12 Teslas. I don't really feel that they've come into clinical practice all that much.
Not yet, not that I'm aware of, at least not in abdominal imaging. I mean, certainly it's a research tool, and even for neuro, and it is still primarily a research tool.
Okay.
I wouldn't even know what the cost would be for a clinical magnet, because the one we have is a research magnet in the University of Toronto.
Okay.
Yeah, so I think the answer for the fleet would be a mix of field strengths and hybrid scanners. That would be the way to go.
Okay, so you'll kind of get like some flow, some 1.5 and 3s, and then maybe some high for research, and then kind of pair it all.
Yeah, that's for an academic center, right? Like if you're in an offsite pure clinical center, it depends on the need, the area of need. So it would be a different answer for those.
It's perfect. And where do you see MR going from here?
Well, I'm certainly not Nostradamus, but yeah, it's. I think it's very fascinating, and I'm really lucky that I might be able to see those changes happening for the next 10 years. Because from what I've seen in the last 5 years, it's been just amazing, like the way it has gone further and further. So I think as we've seen, the deep learning reconstruction techniques have really boosted time image quality. There'll be more progression of that for sure. But I think, with the AI space, even though a lot of people say AI is a bubble and this and that, I think there are real gains to be seen with AI implementation in all aspects of MR. And to that extent, I think it's kind of relatable to other modalities as well. So from an administrative standpoint, we're talking about, using AI-based scheduling, right? AI-based auto protocoling, or at least semi-automated protocoling to reduce tasks. And we've already implemented some of those things in our department with great success. So similar things we are working on in MR as well for semi-automated protocoling.
Oh, yeah. That would save a lot of time, because
that will save at least. So we have to do some pilots and see if that works. But I know there are softwares that can do that. So I think those two big things are on the administrative side. I think on the technologist side, as we discussed, like there's always going to be a shortage of MR technologists, like people graduating out, the numbers to keep up with the number of scanners that are built in. So I think I would like to see AI built into the scanners, where it would predict or help the technologists decide, is this image quality adequate or not? Do I need to repeat the sequences? What are the changes in the parameters that I need to make
to optimize it
further? And I think AI has a huge role in it, and I think that's going to come.
Especially like we find sometimes prostate, the image quality is not good, and the tech has to manually look at it.
Exactly. So like tools like PyQual are built into the system. The images come up, and you get a automated PyQual score. A technologist says the score and says, "Okay, this is not great. I need to repeat it." So I think that reduces the reliance on determining the expertise of a particular technologist, and kind of levels the playing field to a certain standard. So it's all about standardization going ahead and meeting that particular requirement. So, and then even like I would say, take it further. Like the AI could predict which sequence do you need to run. Maybe it might say there might be no need to run this particular type of sequence in this particular patient, because the information you have so far is adequate. So I think these are the kind of changes I'm anticipating in terms of the software side, in terms of acquisition side, and then reporting side. We already know, like there's big strides already being made for automated AI-based reporting. So you look at breast, you look at prostate. There are so many tools available already to kind of reduce the burden or assist the radiologist with detection of abnormalities and take it from there.
Do you think that in the future it'll be more, and the need for radiologists to interpret all of these would become lesser?
I think there will be. I definitely think there will be more tools available for reporting assistance. I call it.
Yeah.
I don't say that this is going to replace the radiologist because it's not a perfect tool.
Yeah.
We know that. We've used that, and it's in with everything, right? Whatever AI tool you use, the answers can be variable. But I think it's getting better and better. So I think that'll reduce the time a radiologist has to spend on instead of going like how I teach the residents, like you need to look at sequence A, B, C, then you look at D. Your AI tool may already do that and present a summary to you, and it may reduce your time.
Oh, yeah.
And then quantitative imaging, which we didn't, I didn't bring it up. I mean, that is the next frontier. Like it's really, really spreading out. And in terms of standardization, it's becoming as a tool for biomarkers. Clinical research trials are using MR quantitative markers. So I think that's the next evolution as well. It's already here.
Okay.
But it will be implemented more in terms of clinical practice, like liver quantitation, or even oncology treatment response quantitation. I think that is a big black box right now, because when we're reporting, let's say, a patient with innumerable melanoma metastases, and you're trying to grade the response, it's really you're giving a kind of a subjective answer to the oncologist.
Yeah, like CT, while there's always been an inbuilt quantitation in terms of the Hounsfield units, MRI has always been signal intensities, which kind of lacked that baseline standardization. But now if we have clear quantitative imaging, then I think the marriage between MRI and AI can actually even become better, like for detecting prostate nodules. Okay, if the ADC is below a certain value, I'm trying to quantify. And similarly, as you speak about like fat and fibrosis and everything in liver.
Yeah.
And that's amazing. Like, so similarly, maybe I guess bone marrow, heart, other tissues can potentially benefit from all of this quantitative imaging.
Definitely. So, yeah, I mean, I think the oncological response based on size, as we know, has a lot of deficiencies. And so I think the automated segmentation tools, giving you an exact segmentation of the metastases burden and then giving a volumetric answer in terms of the response may actually change the way, patients receive these medications or chemotherapeutic agents, right?
Yeah, it's amazing. And one of the things which I often think about is when people ask, is AI going to replace radiologists? The baseline assumption is that this is what we're doing currently, and can AI do something which we're doing currently for the next 5 years, 10 years, 15 years? However, as you point out, MRI has changed so much in the last 20 years. Not just how we do MRI, for what indications we do it, what the sequences are. Because when I started, we spoke about like T1 spin echo and T2 spin echo. I don't think we ever do any of those now, because all the sequences are so far advanced that I don't think anybody would have seen those like original T1 and T2 spin echoes. So all of this innovation is part of like human knowledge and human intelligence. And I don't think an artificial intelligence is going to replace all this evolution which we're going to have. So maybe it might become as good as what we are currently, but by the time it becomes better, we would have still been like 15 years ahead of it, in which we'd be discovering and identifying new things.
Well, we'll have to wait and see.
Yeah. You're the
we may be
wrong. As we have seen now, the evolution of MR has been amazing and incredible to watch. And as you point out, it's just magic. To me, magnetism itself sounds like magic. You just put a magnet, it just attracts an ion. But this is even weirder, that you put a patient in between a magnet and you're able to see inside MRI. But as we have seen, it has become fragmented in terms of subspecialization, in which previously when there were fellowships for MRI, now there really aren't. It's all under each of subspecialty. But things are again coming back again with all of these low field as well as the whole body MRI. So for anybody who's interested in pursuing a career in MRI, especially like medical students or residents, what would your advice be to them? How should they approach MRI overall?
Well, I mean, it's really, you need to have the drive. There has to be an intrinsic interest and intrigue that I want to know more about this. I find this really cool. How's this doing all this stuff? And I think that can build a really successful career, because you're not going to stop then. You're going to try and find more and more answers. And when you try to find more and more answers, you get better and better.
And you end up with even more questions to answer.
Exactly. And then you do more research by asking those questions. So I think that's the fundamental things that drive, being successful in a particular field. But you have to be interested in it. It shouldn't be like, I want to do this because this is fancy or this is attractive or this is economically good. Or those are various aspects which may make you good but not the best.
Yeah, I think the administrators should worry about that, and we should worry about the real curiosity.
Yeah, I think so. It's important for us to drive the field further. So you need to really find those areas. And this is not just related to MR, it's related to any field and not just medicine. You have to have that interest and drive to keep moving it forward. So I think, but from a medical students or even pre-medical students, I think it's important to have the exposure, right?
Yes.
So if you don't know what is MRI and what it can do, it's like ignorance is bliss. So you have to expose yourself to various areas to kind of get intrigued. And I think that's the fundamental thing which is required for young people.
That's amazing. So to all young trainees out there, get interested, learn more about it. Approaches, we're always happy to show you the ropes. MRI is magic, and one of the most satisfying things you will have in life is to use magic to diagnose abnormalities in patients and help patients in their health journey. So, ladies and gentlemen, that was Dr. Kartik Jhaveri, Professor, Director of Abdominal MRI. Kartik, it was a pleasure to have you here.
Likewise, and thank you very much, Satish, for hosting this.
Always a pleasure. Thank you. And hopefully within the next 2 years, we'll bring you back for another episode on something different so that we can all get more of your advice and be inspired as usual.
And whether we were right or wrong.
And whether we're right or wrong about the future. Absolutely.
All right. Thank you.